Hi everyone. Today we are addressing the confusion surrounding ocular migraine versus retinal migraine. The terminology is important because it has implications for diagnosis and treatment. Many patients and even some providers right here on YouTube use ocular migraine incorrectly, and that's why it's in quotes. And this can lead to misdiagnosis and inappropriate management. So we're going to discuss why ocular migraine, the term, should be avoided, what people typically mean when they use the term, the proper ICHD3 terminology, and features of migraine with visual aura and retinal migraine, and approaches to patient assessment and management. So what is the problem with the term ocular migraine? Well, ocular migraine is not recognized by the ICHD3, by the International Classification of Headache Disorders, which serves as our standard diagnostic manual for headache disorders. However, despite this, the term is still widely used in clinical practice and on medical websites, often with different intended meanings. Different people use it for different conditions. Some use it to describe migraine with visual aura, a legitimate diagnosis. Others for retinal migraine, another legitimate diagnosis. And patients often use it as a catch-all term for any visual disturbance they experience in association with a headache. This inconsistency isn't about semantics, but the fact that it results in confusion and may result in clinical errors because the prognosis and management for these conditions are different. Furthermore, using non-standard terminology in medical records creates serious problems, including the inability to perform research properly. So we already talked about this, but just to summarize it more concisely, when someone says ocular migraine, what do they actually mean? Well, they could mean migraine with visual aura, and so this is specifically referring to a visual phenomenon affecting both eyes due to what we call cortical spreading depression. So we have cortical spreading depression, a wave of neuronal and glial depolarization causing migraine with visual aura in both eyes. I have a video on this if you want to learn more about it. It's actually a very interesting phenomenon associated with migraine with visual aura. They may also be referring to migraine aura without headache. Sometimes the outdated terms silent migraine or acephalgic migraine is used. Or they may be referring to retinal migraine. This is a rare but distinct condition affecting only one eye. So it's monocular, while this migraine with visual aura is binocular. And without clarification, we can't know which condition they're describing. And we will talk more about these in detail as the lecture progresses. So migraine with visual aura is actually what most patients and some clinicians incorrectly call ocular migraine. This is an important subtype of migraine recognized in the ICHD3 classification. So let's talk about its features so we can distinguish it from retinal migraine later. The visual disturbances in migraine with visual aura affect both eyes simultaneously. This is because the disturbance originates in the brain's visual cortex, not in the eyes themselves. This is such an important concept that you must know. Again, the primary pathophysiological mechanism is cortical spreading depression. Again, this is a wave of neuronal and glial depolarization that moves across the visual cortex. Well, it moves across the entire cortex, but the visual cortex, its movement across the visual cortex is what results in a visual aura. The aura symptoms are dependent on where cortical spreading depression occurs in the cortex of the brain. When it occurs in the visual cortex, it results in visual aura. So cortical spreading depression results in other aura symptoms, but for this lecture, we're going to focus on visual aura. Now, one of the most distinctive features is the gradual development of visual symptoms. So they typically evolve over 5 minutes or longer rather than appearing suddenly. And this gradual onset is an important diagnostic feature that helps distinguish it from other conditions like transient ischemic attacks, because these usually have a more abrupt onset rather than a gradual development. The visual aura typically lasts between 5 to 60 minutes. Following the aura, or sometimes during it, most patients develop a headache within 60 minutes. However, not all patients experience a significant headache. Some might have mild head pain or none at all, especially in the older population. It's worth noting that migraine with visual aura affects approximately 25% of migraine patients, so a minority of migraine patients, but still quite common. Most patients with this condition also experience episodes of migraine without aura at other times. The visual aura in migraine follows a very characteristic pattern across many patients. Typically, it begins as a small disturbance in the visual field, often just lateral to the center of vision. So this is the center of vision, it may start here. As it expands outward or laterally, it takes on a more C-shape or horse shape appearance. And we'll see an example of this in the following slide. So as this expands, along the expanding margin or edge of this shape, patients often see geometric patterns. So if this is the C-shaped aura, there may be geometric patterns on the leading edge. And left behind in its trail are negative symptoms or a scotoma. And this is characteristic of migraine with visual aura. Now this is actually appearing in both eyes, not just one eye. Again, it's binocular. This is very important to know in regards to migraine with visual aura. And because it's coming from the visual cortex of the brain, the visual phenomenon is still visible with either eye covered or both covered. So this is a visual representation of an aura. And as you can see here, it typically starts as a small area near the center of the visual field, and then it gradually spreads outward, expands outward. It will eventually form a characteristic C-shaped or horseshoe pattern with bright, shimmering, zigzag lights along the expanding edge. And this is what we call the fortification spectrum. Behind the advancing edge of bright lights, as you can see, there's a gray area here representing a blind spot or a scotoma that follows behind the positive visual symptoms. And patients often describe this as an area where they can't see. Now, it doesn't always look like this. Some migraine patients only see black and white aura, or it's mainly just static, like one of the old TV screens. Either way, the entire evolution of this visual generally occurs over 5 to 20 minutes, starting small and gradually expanding outward until it moves beyond the peripheral visual field. Again, this temporal evolution is important diagnostically as it differs from the sudden onset of visual symptoms seen in conditions like a TIA. Also, keep in mind that a patient may think this is monocular or happening in one eye, but what they actually mean is that it's happening in one hemisphere. So it's important to be very good at history taking and understand exactly what the patient means. So unlike ocular migraine, retinal migraine is a recognized diagnostic entity in the ICHD3. This is a legitimate but rare subtype of migraine with specific diagnostic criteria that we'll discuss in the next slide. So let's talk about some of the key features of retinal migraine. Retinal migraine is characterized by repeated attacks of monocular visual disturbance. This means visual symptoms affect only one eye. These visual symptoms can include positive phenomena like scintillations or flashing lights, or negative phenomena like scotoma or complete transient blindness in the affected eye. Now, these visual disturbances are temporary, typically lasting less than an hour, similar to the duration constraints of typical migraine aura. The visual symptoms are usually followed or accompanied by a migraine headache within 60 minutes, though the headache may be relatively mild in many of these cases. Now, the key distinguishing feature of retinal migraine is that only one eye is affected. This strictly monocular nature suggests a different pathophysiology than migraine with aura. So rather than cortical spreading depression in the visual cortex, there are currently two main hypotheses. One is the vasospasm theory, so let me just write it here. And the other is spreading depression, not cortical spreading depression because it doesn't happen in the cortex, but spreading depression. Now, the vasospasm theory suggests that retinal or ciliary circulation is involved. Now, this is a similar pathophysiology to Raynaud phenomenon where we can see the skin go from white to blue to red, white due to the ischemia from vasospasm, then blue due to the hypoxia, and finally red as blood flow returns. The other theory, spreading depression, is similar to cortical spreading depression. Similar, it's not the same because it doesn't happen in the cortex. That's the whole point of the C in cortical spreading depression. So if it doesn't happen in the cortex, where does it happen? In the retina. So spreading depression in the retina, not in the cortex. This distinction in pathophysiology has important clinical implications that we'll discuss later. So the International Headache Society has established clear diagnostic criteria for retinal migraine in the ICHD-3. These criteria help distinguish it from other conditions and ensures diagnostic consistency. You can pause and read it for yourself, but other causes of monocular visual loss must be ruled out. So this may include an ophthalmological evaluation, vascular imaging, or other testing depending on the clinical context. There are very serious emergent conditions that can mimic retinal migraine. Therefore, retinal migraine should be a diagnosis of exclusion. So let's directly compare the distinguishing features and underlying mechanisms of migraine with visual aura versus retinal migraine, as understanding these differences is crucial. Again, migraine with visual aura affects both eyes. It's binocular. Can't emphasize this enough. The underlying mechanism is cortical spreading depression in the visual cortex, a wave of neuronal and glial depolarization that propagates across the visual cortex at a rate of approximately 3 to 5 millimeters a minute. This slow propagation explains the gradual onset and the evolution of these symptoms across the visual field in the pattern we discussed earlier. And usually this includes positive visual phenomena like zigzag lines or scintillations, especially at the leading edge. Contrast, retinal migraine affects only one eye. It's monocular because the disturbance is localized to the retina or its blood supply. The proposed mechanisms we talked about earlier, vasospasm or spreading depression. The onset can be more rapid than in migraine with visual aura, sometimes developing within just seconds to minutes. Patients often experience complete visual loss also in the affected eye, rather than the more complex visual phenomena, although that can happen as well. And it may also progress gradually as well. Doesn't have to be rapid, doesn't have to be complete visual loss in one eye. You could have positive or negative symptoms. This is why the main difference is that it is monocular, not binocular. So migraine with visual aura is actually relatively common. It affects approximately 25% of all migraine patients. So given that migraine itself actually affects 12 to 15% of the general population, visual aura is a frequent neurological phenomenon that is regularly encountered. And this condition has a good prognosis with no evidence of permanent neurological consequences in the vast majority of cases, despite the sometimes alarming nature of the visual symptoms. In contrast, retinal migraine is rare. The exact prevalence is difficult to determine due to the inconsistent use of diagnostic terminology and criteria, but it's definitely much less common than migraine with visual aura. However, retinal migraine may carry a risk of permanent visual loss, which makes its correct identification clinically important. One concerning study found that permanent visual deficits eventually developed in approximately 43% of patients with retinal migraine. That is a significant number. This finding suggests a potential for serious long-term consequences that differ dramatically from the prognosis of typical migraine with visual aura. However, this high figure may be overestimated due to publication bias, so they favor reporting of cases with complications. This substantial difference in prevalence means that when a patient reports visual symptoms associated with migraine, they are far more likely to be experiencing typical migraine with visual aura rather than true retinal migraine. Nevertheless, the potential for permanent visual loss in retinal migraine makes distinguishing between these conditions clinically significant. This is why precise diagnostic terminology and criteria matter. They help identify patients who may need more aggressive management or closer monitoring due to different prognostic implications. So what are these management considerations? The management of both migraine with visual aura and retinal migraine generally follow standard migraine treatment protocols: acute treatments to abort attacks and preventive therapy to reduce attack frequency. However, there is some concern about using vasoconstrictive medications like triptans and ergot alkaloids in patients with retinal migraine given the possible pathophysiology of retinal migraine. So this is a significant difference in management that is vital, especially in patients with other vascular risk factors. For preventive therapy, the standard options for migraine prevention can be considered, including anticonvulsants like topiramate, antidepressants like amitriptyline, beta blockers like propranolol, and calcium channel blockers like verapamil. Also, the role of anti-CGRP medications are currently not known for retinal migraine. There are other special considerations for retinal migraine management, however. Given the potential risk of permanent visual loss, there is a lower threshold for initiating preventive therapy compared to those that have typical migraine with visual aura. While this recommendation isn't based on randomized control trials because retinal migraine is so rare that it's hard to conduct them, but it's still a reasonable approach. Patients with retinal migraine should also avoid anything that might compromise ophthalmic blood flow, including vasoconstrictive medications, avoiding smoking, and avoiding hormonal birth control. So clear communication with patients, colleagues, friends, families, and on social media is essential. This starts with terminology. When someone uses the term ocular migraine, take the opportunity to gently clarify what they mean by this. Ask them to describe the visual symptoms in detail, including whether one or both eyes are affected. This allows you to understand what they actually mean and provides an opening to educate them about more precise terminology. It's also important to explain the difference between visual symptoms originating in the brain versus those originating in the eye. An analogy you can use is to think of the eyes as the camera lens of your phone and the phone itself that processes the image as the brain. Sometimes the problem is with the camera itself. That's what happens in retinal migraine, affecting just one eye. Other times, the problem is with the phone, which processes the images. That's what happens in migraine with visual aura, affecting how the brain interprets what both eyes are seeing. Now, the key takeaways: the term ocular migraine should be abandoned in clinical practice and among the general population. It lacks definitional clarity and creates confusion. Instead, use the specific ICHD3 entities: migraine with visual aura for the bilateral visual phenomena originating in the brain, and retinal migraine for monocular visual disturbances. Using accurate terminology improves communication, research, and patient care. Thank you.